Sir, a 23 years old Primi Mrs. Hiramani Hemram, coming from Annanur, has come for same confinement with a history of present pregnancy of 9 months of amenorrhea with last menstrual period on 18/9/2022 with expected date of delivery on 25/6/2023. First trimester, pregnancy confirmed at 4th week, booked and immunized, history of EC fatigability plus present, no history of palpitations, no history of dyspnea, no history of loss of appetite, and no history of fever with rashes, and no history of bleeding PV, no history of excessive vomiting and ingestion of drugs. In second trimester, quickening felt at 20th week, iron and folic acid tablets taken, and injection tetanus toxoid 2 doses given, no history of headache, no history of swelling of legs, and no history of blurring of vision. In third trimester, no history of discharge and no history of bleeding per vaginum. No history of decreased perception of fetal movements and no history of lower abdominal pain and no history of fever with rash and no history of increased urination. Total weight gain during pregnancy is 6 kg. Menstrual history, attained menarche at 13 years of age, regular cycle which is 5 of 30, not associated with pain and clots. Last menstrual period 18th September 2022. Marital history, married since 2018, non-consanguineous marriage. Past history, no history suggestive of diabetes mellitus, systemic hypertension, tuberculosis, asthma and epilepsy, no history of surgery in the past, and no history of blood transfusion. Personal history, mixed diet, normal bowel and bladder habits, no history of drug allergy. General examination, patient conscious, oriented, afebrile, pale or present, no icterus, no cyanosis, no clubbing, no lymphadenopathy, and no pedal edema. Thyroid and breast normal, spine normal. Vitals, pulse rate which is 88 per minute, regular in rhythm, normal in volume, felt in all peripheral sites. Blood pressure which is 90 of 60 millimeter of mercury measured in left upper limb. Respiratory rate which is 15 per minute, height 155 centimeter, weight 53 kg, BMI 22 kilogram per meter square, and weight gain total is 6 kg. Obstetric examination, inspection, abdomen longitudinally enlarged, umbilicus is in midline, linea nigra present, no scars, no engorged veins, and no abdominal wall edema. Palpation, patient examined in supine position with legs flexed. Fundal height corresponds to 36 weeks of gestation and abdominal girth is 98 centimeter. Fundal grip, broad, firm, bulky, rounded mass and non-volatile mass felt suggestive of breech. Lateral grip, hard, resistant, slightly curved mass felt on left side, probably the back. Irregular, firm nodules felt on the right side, probably the limbs. First pelvic grip, which is hard, globular and independently volatile mass felt suggestive of head. Auscultation, fetal heart rate 152 per minute and regular. Fetal heart sounds heard below and to the left of the umbilicus. Cardiovascular system examination, first and second heart sound heard with no murmur. Respiratory system, normal vesicular breath sounds heard, no added sounds. Examination of airway, Malambati grade 2, interincisor graph, 3-finger breath present, thyromental distance adequate, neck movements normal, and no loose tooth and no dentures. Diagnosis, a 23 years old female with symptoms of EC fatigability for past 1 month as admitted for safe confinement is provisionally diagnosed as anemia complicating pregnancy.
How many weeks of gestation? What is the
So
LMT?
36, sir.
36 weeks. How
Yes,
long she has been feeling this EC fatigability and palpitations?
So for past 1 month, sir.
1 month. Okay. How do you straight away make a diagnosis that she is anemic? You are not. Did you examine anything? Do you get any investigation results or anything to say that she is anemic?
Yes, sir. I would like to investigate further and I will confirm.
Well, the provisional diagnosis is anemia, isn't it?
Yes, sir.
What are the other features of anemia in a pregnant woman? Apart from
Signs and symptoms.
fatigability can happen even for normal women also, normal pregnancy.
Yes, sir. So palpitations can occur, sir. Palpitations, loss of appetite, dyspnea.
Dyspnea for the grade dyspnea. What is the degree of dyspnea? Is it grade 1 or grade 2? Is it grade 1, grade 2, grade 3, grade 4? You should grade always. Whenever you say dyspnea, you should say whether the lady is finding it difficult even for her routine regular work or only for strenuous work or when even at rest. Yeah, all the 4 grades you should ask and find out.
Okay, sir.
Any other features common to anemia apart from this easy fatigability?
Signs of pallor present, sir, on
Signs of
clinical
failure.
examination.
Oh, symptoms. Patients complain.
Patient complaint, no, sir.
And they have giddiness.
No, sir.
The patient with severe anemia, can they have giddiness?
Yes, sir.
What is the reason for the giddiness if you say yes? What is anemia, first of all? What is the pathophysiology in anemia?
Sir, qualitative and quantitative reduction in hemoglobin or circulating red blood cells are both, which can lead to reduced oxygen carrying capacity, sir.
Capacity. So oxygen is not being delivered adequately to various tissues. So which is the most
Yes, sir.
sensitive organ which will not stand on lack of oxygen even for a very short period?
Brain, sir.
Brain. So if you have severe anemia and there is inadequate blood supply and oxygen delivery to the brain, can they not have giddiness or transient ischemic attacks?
Yes, sir. They can have, sir.
Possible. Did you ask that
Yes,
question?
yes, sir.
Did she say yes or no?
No, sir. She said no, sir.
Okay. So how is the giddiness prevented in this lady? Even though you are making a diagnosis of anemia, what are the
Yes, sir.
compensations that happen in the body to counteract this lack of carrying capacity of oxygen?
Sir, increase in cardiac output, sir.
Okay, very good.
Increase in respiratory rate, sir.
Decrease in respiratory rate, okay.
The decrease in viscosity of blood and
Viscosity of
shift
blood.
of oxyhemoglobin dissociation curve to right, and
Right,
increase in
very good.
renal secretion of erythropoietin, sir, which are the
Good point.
compensatory mechanisms
What about
to
2,3
prevent
dBc?
giddiness in. Yes, sir. Increase in 2,3 dpg concentration will occur, sir.
So these are all adaptations in the hematological system. But ultimately, at the cellular level, how is oxygen being increasingly delivered? Now, whatever adaptations you have said, like the increase in cardiac output, increase in heart rate, increase in respiratory rate, all these things are measures to carry more oxygen to the peripheral level and to the tissue level,
Yes, sir.
decrease
Yes,
in
sir.
viscosity. The only finding that oxygen ODC curve, oxygen dissociation curve shifting to the right indicates that blood can easily deliver the oxygen to the tissues. But ultimately, at the tissue level, is there any molecular change that is happening in anemia? What is TIF? Have you heard of the word TIF?
No, sir.
Not heard. Anybody else? Debardi, are you there?
Yes, sir.
What is TIF? TIF. It is considered as the current concept in the adaptations, very important adaptation that happens in anemic patients. Not TIF, sorry, HIF, HIF, HIF. Have you heard of that word, HIF? hypoxia inducible factor. Have you heard of that word? Hypoxia inducible factor, which is a dimeric protein which increases to cause angiogenesis. It's a transcription factor which causes changes or production of genes which will result in angiogenesis and utilization of oxygen at the mitochondrial level. HIF, hypoxia inducible factor 1. And that is the common concept which says that at the cellular level, all the other mechanisms which are described in the books like increased cardiac output, increase in heart rate, oxygen dissociation curve shift, increase in 2,3-DPG, all these things are mechanisms which are able to carry and deliver the oxygen to the tissue level. But ultimately, the oxygen has to be used by mitochondria for aerobic respiration. That is the idea. Isn't it? So, and that is carried out by this hypoxia inducible factor 1, which is generated to cause more increase in vascularity and permeability of the capillary membrane, so that oxygen can traverse easily from the blood into the tissues and get into the mitochondria. Okay, so that is the ultimate factor which decides how the adaptation is taking place. Okay, and what do you think is the cause of this anemia in this lady?
Sir, physiological, there are three types of causes are there, sir. Physiological, acquired, and genetic, sir.
Physiological is common to all pregnant women, but they don't
yes, sir. Hemodilution.
have any symptoms, isn't it? All natural pregnancy all women will have this physiological anemia of pregnancy. And the common question asked in the examination, what is the explanation for this anemia? How does it happen?
So hemodilution, physiological hemodilution will occur during pregnancy, sir.
Say that hemodilution, or should we say the values of RBC and the plasma?
Yes, sir. Increase in plasma volume will be more than the increase in RBC volume.
RBCs. Disproportionate
RBC volume will
increase in plasma to the increase in RBC. That is the correct answer. Okay? Disproportionate increase in plasma volume in proportion to the number of RBCs increase. This is what is called physiological anemia. That is a mechanism for helping the mother. Okay, it will help to make the blood less viscous so that it can flow easily through the placental circulation. That is the reason why it is not meant for making the mother hypoxic. It is meant for the baby to survive well, because it will decrease the viscosity and make the blood flow easily through the placental circulation. That is the main reason for this physiological anemia. That is why mother does not suffer from the actual features of hypoxemia in physiological anemia. Okay, what are the other types you said? Acquired and?
Sir, acquired cause, genetic causes, sir.
What are the genetic causes?
In sickle cell anemia, thalassemia, sir.
They are varieties of anemia. Okay. Acquired causes?
Acquired causes. So nutritious causes, infectious causes, hemorrhage causes, bone marrow suppression causes, and renal disorder causes.
Very good. Five points are mentioned. So, did you ask all the questions to find out what is the etiology for this anemia? How do you find out whether it is nutritional? What question you should ask in the history?
So, iron and folate-rich foods, whether have taken or not, I should ask.
That is, doctors only prescribe. Not every pregnant woman will not know that they have to take iron and folic acid. Only when they go to the doctor with a confirmation of pregnancy, the doctor will prescribe iron and folic acid right from the time they have confirmed that it's a pregnancy. Okay, but what are all the changes due to pregnancy, which can prevent the mother from eating properly and getting proper nutrition, especially in the first trimester.
Sir, intake of iron tablet will cause GI upset, sir. Gastrointestinal upset it will
No.
cause, sir.
Even before you prescribe iron and then she starts taking, is there any normal change or normal symptom or normal thing that happens in the first trimester?
Hyperemesis gravidorum can occur, sir.
That is morning sickness or hyperemesis gravidorum. So if the mother is not, sometimes the hyperemesis can be so severe that mother gets acutely dehydrated, becomes so weak, hypotensive, all these things can happen. So that is the first and foremost. So your question should be targeted toward finding out whether the mother suffered from severe hyperemesis gravidorum or morning sickness during the first trimester, which prevented her from taking her normal diet itself. Okay. Then you should ask whether she was prescribed any iron and folic acid and whether she was taking it properly or whether she stopped it because she could not tolerate the iron. Okay? These are the two questions that you should ask to find out whether it is of nutritional cause. What about infection? You said the other of the four causes are infection. How do you know what infections can cause to anemia during pregnancy?
So tuberculosis can occur, sir. Parvovirus B19 infection, hepatitis B infection, worm infestations can cause anemia, sir.
Very good. Then, so this is second point. What are the other reasons you said for intrapartum or pregnant anemia? You enumerated 5 causes, isn't it? One you said.
Yes, sir. Yes, sir.
Second is infection. Third, hemorrhage. What are all the hemorrhages that can happen cause anemia? Can the mother have a bleeding piles?
So hemorrhoid, yes, sir. Hemorrhoid disorder.
Hemorrhoid. Can she have a placenta previa?
Yes. Antepartum hemorrhage, postpartum placental abnormalities can present with anemia.
Placental
Acute causes.
abnormalities. So, and if she had menorrhagia even before becoming pregnant because of irregular menstruation, she would have become pregnant even anemia would have existed even before she became pregnant, isn't it? So that is also an important history that you should ask. Right.
Okay.
So these questions should be targeted to find out whether the anemia has been existing even before the patient became pregnant, or it has been due to inadequate iron and folic acid intake intrapartum, that is during pregnancy, so that she gradually became anemic and then the symptoms got worsened as the pregnancy progresses. What is the hemoglobin value you will accept it before during the first trimester and then the second and third trimester?
Sir, 11 gram per deciliter during first and third trimester, sir. 10.5 gram, more than 10.5 gram per deciliter during second trimester, sir.
Trimester, very good. So if that is the value, then it can be accepted as a normal value. Right. Okay. Supposing this patient you examine clinically, what are all the changes that will be caused by anemia in the various systems in the body? What is the cardiac?
So in general examination, we can pallor can be present, pedal edema can be present, and generalized anasarca can be present, sir.
What is the cause?
In respiratory.
What is the reason for this pedal edema, generalized anasarca?
It's a cardiovascular manifestation because of anemia.
No, that's why I'm asking, if you find pedal edema, generalized anasarca, what is the reason for that? Cardiovascular system is involved. What is the correct description of the cardiovascular system change that you should say?
Congestive heart failure can occur.
Patient is in heart failure. Okay, circulation is not maintained properly. Okay, so as long as the heart is pumping well, you won't have any edema. But once the heart starts failing because of excessive workload, all the from 34 weeks onwards, it has been pumping at a very high rate and increasing contractility. So over the period of time, it becomes fatigued and start sluggish activity.
Feeling.
So it is not able to pump adequately. That means the patient is in failure and they develop edema. Okay, right.
Yes.
But if without edema or anasarca, what will be the findings in the cardiovascular system?
Can present with ejection systolic murmur and any
What
diastolic
about
murmurs.
start with the pulse? Always cardiovascular system.
Yes, sir.
Start
Yes, sir.
from the pulse.
So it can be high volume or high bounding pulse can be present.
Rhythm, character,
Right.
pulse always you describe as the basic. Don't jump to high volume, lapsing, all that. Rate will be always higher than normal.
Higher
tachycardia and severe tachycardia can be there, number one. Is
Yes,
it a bounding pulse or a very low volume
Yes, sir.
pulse?
Bounding pulse, bounding high volume pulse will be
High
there.
volume pulse. And then,
Yes.
is it collapsing?
Collapsing. No, hyperdynamic, sir.
Hyperdynamic only. When will you get a collapsing pulse? Aortic regurgitation?
Yes, sir.
This is where you examine holding the pulse in both hands. Okay, as you increase the height, then there is a drop in the volume. That is called the collapsing pulse. Okay, but here it will not be like that. It will be a hyperdynamic, bounding pulse in all the positions. Okay, right. What about the heart? When you auscultate, or first of all, palpate the heart, what are the changes that you see before auscultation? How will be the apical impulse? When the heart is contracting,
Tapping in nature, sir.
Tapping
in nature. Sir.
Tapping means it is very soft contraction. It just touches and goes away. Heaving means it is in contact with the chest wall for more number of time. Isn't it? When will you get a heaving apical impulse? Suddenly,
in all hyperdynamic
can jump to all basic third MBBS questions. Okay. So heaving apical impulse is usually when the ventricular mass increases, like in hypertrophy or dilatation, then only it will be in contact with the chest wall for a longer amount of minutes or seconds of time. Then you call it as heaving apical impulse. Okay. Here sometimes it may be heaving because of the violent or strong contractions of the left ventricle. You may get a heaving apical impulse. Okay, right. Then auscultation. You may get you said a murmur. Ischemic murmur. Is it a systolic murmur or a diastolic murmur?
Systolic murmur.
Systolic murmur, because it is forcefully injecting the blood through the aortic valve. So you get a ejection systolic murmur. Okay. So these are all the common findings in anemia affecting the cardiovascular system. What about the other systems? Neurological, CNS. We have already said some symptoms in CNS.
Yes, sir.
Patient can have transient ischemic attack like blackout, giddiness,
syncope,
all these things are possible.
Yes.
Okay. What about liver, kidney? Can the liver be enlarged? If the patient goes in for left ventricular failure, automatically what will happen?
Yes, sir. Liver congestion will occur.
Right heart
failure or liver congestion. Tender hepatomegaly, hepatic congestion can occur.
Similarly, renal problem also can happen. Okay. So these are, and musculoskeletal, always tiredness, weakness, all these things will be there. And because of lack of oxygen to the muscle, they become fatigued much faster. That is the reason for the fatigability. Okay. Right. So if this patient is now come to the hospital with symptomatic anemia features, how are you going to? You said she has come for safe confinement. How are you going to manage her confinement?
Sir, I would like to investigate further, sir.
Very good. What are the
With blood
investigations?
investigations, complete hemogram, sir, peripheral smear,
Okay.
mean corpuscular volume, mean corpuscular hemoglobin concentration, mean corpuscular hemoglobin, sir.
Okay. Why do you want
Followed
to
by,
do that?
sir,
Why do you want to do that? As a routine, or is it with a purpose you want to do all these investigations?
sir, complete
You want to
hemogram is routine
identify
and
the type of anemia.
cause,
Isn't
yes,
it?
sir, cause of anemia. Yes, sir.
Not cause. Cause is
Yes,
different from type, variety, classification of anemia. Cause is nutritional, hemorrhage, infection, all that what you said is cause. But when you
yes,
want to do a peripheral smear and the head hematological indices, it is to identify the type of anemia.
types.
Okay, type is different from cause. What are the types of anemia?
So
Because anemia
microcytic hypochromic
classification is
anemia,
various. Microcytic,
microcytic hypochromic anemia, macrocytic anemia, normocytic anemia, sir.
normocytic anemia. Which
Microcytic
one?
anemia which occurs in
Hmm.
sir, iron deficiency anemia and thalassemia.
Very good.
Macrocytic anemia which occurs in vitamin B12 and folate deficiency along with alcohol abuse.
Very good.
Normocytic anemia which occurs in hepatic hemorrhage and bone disease.
Excellent. Okay, so that is the purpose for which you do that, to identify the type of anemia, because the treatment will be different. If it is hypochromic, hypocytic, microcytic anemia, you have to give iron. If it is macrocytic, you have to give folic acid. If it is normocytic, normochromic, you may have to replace the blood loss because it is hemorrhagic. Okay, so that is the reason why you want to identify the type of anemia by doing this investigation. Okay, supposing it turns out to be a iron deficiency anemia. The patient is having a microcytic hypochromic anemia, which is indicative of iron deficiency. How do you treat that patient at this
Three
stage?
modalities of treatment available, sir. At this stage, since he is near to her due date,
36
we
weeks,
would like to
you have
prefer blood
still
transfusion.
4 weeks left. You have another 1 month time is there to prepare her. Do you want to immediately deliver her?
We'll wait and
Okay, so how do you
manage
treat
conserve.
the anemia before she delivers?
Sir, parenteral management, parenteral administration of iron,
Why
intravenous
can't you
management.
start on oral treatment if she has not had proper oral treatment? Why not start her on oral iron?
So it will take 6 weeks to make the hemoglobin normal, sir.
Very good. So it is
Oral
it
treatment.
takes a lot of time. So you have to
Since
go
her due
for
date is very close.
very good.
Yes, sir.
And another reason may be she might not have taken properly the iron because she could not tolerate it by oral food. Okay? So two reasons why you could not start oral is: one, it takes a longer time to correct the anemia. Second, probably she stopped taking iron because she was not tolerating it well. So there is no point in trying it by oral route again, right? So what is the alternate?
So in parenteral, two routes available. One is intramuscular and one is intravenous routes.
Very good. What are the advantages and disadvantages of both? Intramuscular, will you prefer, supposing you are married? Are you married? No. Supposing you get married and your wife becomes pregnant and she is slightly anemic, would you like your wife to have an iron injection?
Intravenous route I will prefer.
It will be very painful.
It will
Iron
cause.
injection has
Yes,
got
sir.
a very painful injection.
Be painful.
And it has got other complications also. You have to administer it in a
Yes, sir.
particular way so that it doesn't come out and stain. And the injection abscess is very common with iron injection in the gluteal region. Okay, so these are the disadvantages of intramuscular iron. So people prefer to give intravenous so that it directly go into the blood. How much of iron is needed normally? Because iron transport, iron in metabolism can be asked in the examination.
Okay,
What is the normal requirement of iron for a pregnant woman?
so in yearly pregnancy, it is around 2.5 milligram per day. From 20 to 32nd week of gestation, it is 5.5 milligram per day. From 32 to 40 weeks of gestation, it is 6.8 milligram per day, sir. Total requirement is 800 to 1000 milligram overall.
So how do you administer parenteral iron? What are the preparations you know of? What are the disadvantages or complications of this IV route?
IV. Sir, it will cause local thrombophlebitis, sir. And it can
Before
cause
that,
fever, malaise. Sir,
anaphylaxis or allergic reactions? Is it the most?
yes, sir. Yes, sir.
So always first you have to say the most dangerous complication, and then go for milder complication. Okay? So parenteral IV iron can sometimes cause anaphylaxis. Right. Then you can say about the thrombophlebitis, reaction, fever, all these things. Okay?
Okay, sir.
What are the commercial names of iron preparations that are available for IV administration?
So iron sucrose, sir.
Very good.
Iron sorbitol citric acid complex and iron dextran, sir.
Very good. So these are the two that are given. So iron supplementation by parenteral route is the first choice. Supposing the anemia is very severe, it is less than 7 grams. Hemoglobin is less, and the hemoglobin is less than 7 grams. Will it be amenable to this iron treatment? The patient is very symptomatic. He is dyspneic at rest.
No, sir. I will prefer blood transfusion, sir.
Blood transfusions. So before giving blood transfusion, what are the precautions you should take in an anemic patient with severe dyspnea and hemoglobin less than 7 grams? When you plan to increase the hemoglobin by blood transfusion, what precautions you should take? Can you just like that start an IV and start giving the compatible blood? What is the one important
Blood grouping
thing?
typing I have to do, sir. Blood grouping and typing.
Yes. We will give only compatible blood. We will not just infuse randomly. Okay? But before planning or thinking about blood transfusion, what is the one important clinical condition you should rule out?
Volume overload should not be there.
Patient is whether she is in failure or not. Okay. Auscultate the lungs, examine the chest with an echo, see the ejection fraction, see whether she is in failure. If already the heart is not pumping well and you start giving 2 or 3 units of blood, what will happen? She may develop with a pulmonary
Volume
edema.
overload. Yes, sir.
Not volume overload. The exact complication is pulmonary edema. Okay? So you must make sure that the heart will be able to pump the blood that you are infusing into her. And she is not in acute failure. That is the most important thing before starting a blood transfusion. Supposing she shows some mild crepitations in the base of the lung and she is dyspneic at rest and her hemoglobin is less than 7. Is there any way to administer the blood for her to correct the anemia?
So prophylactic Lasix administration can be given along with blood transfusion.
Good. You must give a diuretic, reduce the fluid overload on her, and then give only. Can you give whole blood or packed red blood cells?
Packed RBCs.
You have to
Red blood
give
cells.
only PRBCs. Okay, don't give whole blood. That is the second. Okay, so you can administer diuretic, reduce the volume, improve the heart condition, and then start infusing very gradual titrated doses of packed red blood cells and monitor her in a dependency unit while the transfusion is going on. Don't just start it in a ward where there is no proper monitoring of the patient. Okay? And periodically watch out for the urine output and the patient's hemodynamic stability. Okay, this is the thing that you
Okay,
do, right? So you have given blood transfusion and the blood hemoglobin has increased and patient also clinically feels better. The dyspnea comes down, fatigability comes down. Now the physician says we better deliver the baby. What are the options for this lady who has been corrected of her anemia by blood transfusion? If she is to undergo delivery, what are the options? Supposing the physician says, yeah, all the cephalopelvic parameters are normal, I would like to allow a vaginal delivery for this lady. That is the choice by the obstetrician and the patient. They don't want an operative delivery. What are the, as an anesthesiologist, how can you help the patient?
sir, make the person in a comfortable position, sir. We'll
Okay,
provide oxygen supplements, adequate analgesia,
very good.
and
Analgesia
appropriate
in the form of
antibiotics,
what?
sir.
How will you give analgesia?
Sir, Internox, labor epidural.
Very good. So labor analgesia. Instead of saying adequate analgesia, you should say I would provide labor analgesia during the delivery because they want to deliver the
Yes,
child. Okay? So at 36
yes,
weeks, can the child be born automatically? You said she is 36 weeks of gestation.
yes.
The patient admitted 2-3 days, you are given blood transfusion, hemoglobin has come to 9 or 10, and the physician says we better deliver this baby. So how do they deliver this at 37 or 38 weeks before the natural onset of labor?
And
Normally, what do the physicians do? They want to deliver a child before the normal onset of labor.
cut short, sir. Cut short the second stage.
They induce labor, not the cut shorting or anything. They start oxytocin. Have you not done as a house surgeon
Yes,
during the labor ward? So they
yes, sir.
induce labor with infusion of oxytocin, isn't it? So that is how they
Yes.
artificially induce the labor, try to deliver the child. So what precautions should be taken when you do the oxytocin infusion to induce the delivery or labor?
Sir,
Normally, how is it done?
sir, ARM can be done, sir.
ARM can be.
Oxytocin
First
infusion, they will.
ARM is done or first oxytocin is started?
Oxytocin will be started, sir.
You have to see whether the uterus responds or not, isn't it? So you start
Yes,
the oxytocin at the dose of 5 units per hour, isn't it? These are all the
yes,
duties of housemen. Usually they will write the instruction and go and you will be sitting and watching. Have you not done it in the labor ward? Starting oxytocin and then monitoring the uterine
yes,
contractions. All these things you would have done, isn't it? So that is
yes.
how you induce the labor, and then once the contractions become powerful, you do rupture of membranes, and then try to
Yes, sir.
progress the labor and deliver the baby. Okay. So during this time, you must be very watchful. What is the effect of oxytocin on the cardiovascular system? Apart from the uterine contraction it produces, what are the effects of oxytocin on the cardiovascular system?
So it will cause hypotension, sir.
Yeah, why?
Systemic hypotension,
Why?
vasodilatory action, sir.
Vasodilated reaction, and if it also reflex tachycardia will happen.
Reflex tachycardia will be there, sir.
So you have to be very careful while giving oxytocin in a patient who has been corrected of her anemia, because undue tachycardia will definitely harm the myocardium and it will cause a respiration of failure also can happen. Okay, so you don't want to happen. So you induce labor. At the time you give adequate analgesia either by Enternox or by your lumbar epidural, which is so that the stress on the cardiovascular system is very minimal. Okay, right. Supposing what other precautions you should take before you induce labor in this patient? Especially the gynecologist, what point they should look into? Does the position of placenta got any relevance to this section of labor?
Yes, sir.
What is the importance of the position of placenta?
Placenta previa may cause
We
acute
should
blood
rule out
loss which
any
results in
abnormal
anemia.
placentation. Okay, so
Yes, sir.
whenever you want to induce labor in patient, you must rule out abnormal placentation like placenta previa, placenta previa, placenta infrita. Okay, all these things. How do you find out that? What simple test will tell you about the placental position and its location?
Vaginal examinations.
Will you do a pervaginal if there is a placenta previa? Just
Ultrasound.
contraindication for PV is placenta previa. It can sometimes cause torrential bleeding. Ultrasound is there. Nowadays, everybody uses ultrasound. So,
Yes.
obstetricians also use the ultrasound. In fact, during the antenatal ultrasound, they will definitely mention about the placenta, where it is located, whether it is in the proper position or in the placenta previa or in the lateral wall. All these things will be mentioned. Okay. So you must make
Yes.
sure that the placenta is in normal shape. Why it is important to know the placenta, especially in an anemic patient undergoing a normal vaginal delivery?
Acute blood loss can happen, sir, during delivery,
Excellent.
which
It can
further
have
worsens
a
anemia, sir.
very good. It can have a torrential hemorrhage. Okay? Both intrapartum or postpartum hemorrhage can happen, which is common in anemic patients. So it will aggravate the condition and will worsen the condition. Excellent. Very good. Right. So this is the management for normal vaginal delivery if it is planned. On the contrary, if the patient is taken up for a cesarean section because of say they induce labor, there is no progress or there is a fetal distress and the physician wants to take up the patient for emergency or semi-emergency cesarean section. And what are the precautions you will have to take? Or what is the
So
how do you administer anesthesia for that?
hypoxia should be avoided, sir.
Okay.
Avoid
Hypoxia should be avoided
minimizing.
for any patient. Here also it is much more important. Okay.
Yes, sir.
Hmm. What else?
Adequate analgesia should be provided during cesarean section, sir.
Okay.
Avoid minimizing cardiac output, sir.
Imagine cardiac output.
Yes, sir. Avoid minimizing cardiac output.
Cardiac output, if you minimize, it will happen. Already she is anemic. Hypotension. You want to prevent hypotension. Is that what you mean by that? You want to avoid hypotension or you want to reduce the cardiac output? Minimize the cardiac output means there is a decrease in the cardiac
Sir,
output.
avoid minimizing cardiac output. I said avoid
Avoid.
minimizing cardiac output.
Okay, okay, double negative.
Sorry,
Okay.
sir. Sorry, sir. Yes.
Right, right. Okay.
Yes.
So you have to maintain the cardiac output. So ultimately, what is the technique of anesthesia? You want to give a spinal, or you want to give an epidural, or you want a combined spinal epidural, or you want a GA?
Combined spinal epidural, sir.
Eh,
With low volume of spinal.
Now, understand the situation. You have the physician wanted to try normal vaginal delivery. You have placed an epidural catheter for analgesia. There is no progress of labor or there is a fetal distress and the physician suddenly decides to do a operative delivery. Now, how will you give anesthesia for surgery? There is already an acting epidural is there. Your epidural analgesia
Yes,
is working very
so
well.
low volume spinal I will give, sir, and I supplement with epidural.
Why not convert the labor analgesia into a more powerful anesthesia surgery? Can it be done?
Yes, sir.
Can you inject a higher percentage? What is the concentration
Yes,
of
sir.
local anesthetic you will give for labor analgesia?
Sir, sorry, sir.
What is the concentration of local anesthetic you will use for producing labor analgesia?
0.5% of bupivacaine.
For labor analgesia, we give 0.5% bupivacaine.
No.
What is
So
walking
0.06.
epidural? Very, very low concentration.
Since
You don't want any motor blockade. We give
yes, sir.
0.5%, mother will develop motor blockade and she will not be
Yes,
able
sir.
to cooperate for a normal delivery. So for labor analgesia, we normally give only 0.125 or even lower than that 0.0625. Okay. At that concentration, you produce only selective sensory and autonomic blockade. You
Okay.
don't produce any motor blockade. That is why it is called walking epidural.
Walking epidural.
You want the motor blockade to be intact so that father also can push and help in delivering the baby. And if you have such a good working epidural catheter, if you give 0.5% bupivacaine, it will cause motor blockade also, and it will be helpful
Yes.
in operative anesthesia also. So the first choice
Yes,
is to convert the labor anesthesia into operative anesthesia by injecting a higher percentage of local anesthetic agent. Second, if supposing that labor anesthesia is not acting well or not satisfactory, then you can go for a subarachnoid block along with this and give a
yes.
heavy bupivacaine like 0.5%. Heavy bupivacaine can be injected, right? Or if
Yes.
that is the first time you are going to do, you can straight away go for a single shot epidural.
Vein spinal.
That's fine.
Okay, sir.
If there are any contraindications for the central neuroaxial blockade and you are forced to give general anesthesia, how will you administer GA for a emergency cesarean section?
Sir, we'll connect all the standard monitors, sir,
Very good. Okay.
with wide bore IV cannula.
Very good. Excellent.
Sir, yeah, anti-Sailogagas injection glycopyrrolate.
Okay.
We'll go for rapid sequence induction with injection propofol and
Before
scoline,
that,
sir.
before that,
Adequate
very important.
pre-oxygenation should be done.
You should never forget that
Adequate pre-oxygenation.
pre-oxygenation is a very, very important step in especially pregnancy general anesthesia. Why? Why you want to do the
So their
pre-oxygenation?
FRC will be very low.
FRC is low. So
Low.
FRC is low. What
So
is the implication of that?
shorter period of apnea can be increased.
Shorter period of safe apnea period. Patient will desaturate
Safe apnea.
faster. Okay. So
Yes,
by
sir.
giving 100% oxygen for full 5 minutes, you can prolong the safe apnea period. These are all the terminologies that are expected out of you in the examination. So you can prolong
Okay,
the safe apnea period.
safe
That is
period.
the answer that you have to give. Okay. So
Yes.
and what about the position? When you want to do GA, what is the position of the patient? You have to give importance to.
So reverse Trendelenburg.
Reverse Trendelenburg. What is LUD?
Left uterine displacements.
You should never forget
To
that.
avoid high
These things you have to
iotacaval
do in
compression.
examination because these are basic points examiners expect from you. So even without being questioned, you should be able to say Whenever the patient is placed in the table, the first answer, pregnant woman should be placed in left uterine displacement with a 10 to 20-degree head up tilt, and then pre-oxygenation is done while you are giving the antisyllagogue, then plan for RSI. When you say RSI, the question will be, what is the importance? Why should you give RSI for a pregnant woman?
So all pregnant women should be considered full stomach even if they place posted
Selectively starved and
planned for
all that.
NPU for 8 hours. Yes, sir.
Very good. So, what is the reason why they are considered as full stomach? Normal physiology question.
So there will be delayed gastric emptying is there, sir,
Very
during
good.
pregnancy.
Okay.
And raised intragastric pressure will be there.
Ah,
Lower esophageal sphincter tone will be reduced, sir, because of
very good.
progesterone during pregnancy.
So, what is the normal lower esophageal pressure called? Is there any particular name for that lower esophageal sphincter pressure which prevents any regurgitation happening because of the increased intragastric pressure? Supposing police people don't want you to go on a particular road, they want to block the road, what do they use? Traffic. They put some steel things, what do you call that?
Cork.
Barricade. Okay, it's called barrier pressure. Okay, the lower esophageal
Okay.
pressure is called the barrier pressure. It forms a barrier for the regurgitated fluid to come out of the stomach. So that is also altered. Number two, any other reason for the easy regurgitation to happen? One you said is the delayed gastric emptying. Second is the abolition of barrier pressure. That is, lower esophageal sphincter becomes lesser. The pressure becomes lesser than the intragastric pressure. Any other reason? What about the angulation of the fundus in connection to the esophagus? Will it be a normal angle? Normally, the
Pinch
stomach
cork
is
effect will be removed, sir.
Ah,
Pinch cork effect will be removed.
yes, it will become more or less straight, isn't it? So these three reasons are there for the gastric fluid to come out into the pharynx to get aspirated. Okay? So these are the questions that will be asked with regard to RSI. And how do you do the RSI? That is another common question they may ask you. Supposing you have to give GA for a pregnant
Cellix maneuver.
Cellix maneuver.
Applying
So
cricoid
after
pressure of 10 Newton
pre-oxygenation,
in.
huh?
Is it nothing, sir.
No, after pre-oxygenation, how do you proceed to do the RSI? Tell me all the steps. Can you do it alone?
No, sir. Well trained technician should be
You
assistant
should
to
have an assistant. That is the answer expected from you. You always need somebody who knows how to give a cricoid pressure or Felix maneuver. So you must arrange for a help. And then that person should place his fingers on the cricoid cartilage even before the patient becomes unconscious. Identify the cricoid cartilage and keep his index and thumb finger over the cricoid cartilage without pressing it. Just hold it. And then as you are giving the induction agent, the patient loses consciousness.
From loss of consciousness to till the cuff pressure, cuff inflation, you should apply the cricoid pressures.
Okay. So what is the induction agent of choice? Which induction you prefer for a pregnant woman? Especially if you want to do RSI. Propofol. Supposing you use propofol, do you have to inject propofol rapidly or slowly?
Rapidly, sir.
So what will happen if
it
you
will cause
because
painful, sir. Painful on injections.
Pain is okay, but more than that, pain you can abolish by adding xylocard.
Xylocard.
But if you inject propofol rapidly at the rate of 2 mg per kg body weight, What is the cardiovascular effect of
Hypotension and
bradycardia? Okay, that can happen. Severe bradycardia and hypotension can happen. Whereas tipentone, even if you give 250 milligram rapidly, will this produce a severe hypertension like propofol?
No, sir.
It will not. Okay, and faster acting also compared to propofol. Tipentone is faster acting. So for RSI, the preferred drug is tipentone.
Thiopentone.
The rate of 3 to 5 milligram per kg body weight IV, followed immediately by hexametonium 1.5 milligram kg. All the doses we should be able to take correctly. So the disadvantage, propofol also can be used, but when you use propofol, you have to inject it very slowly, so to avoid the high sudden hypotension. Okay, so that is the reason why propofol is not the ideal drug for RSI. You can always go for hexametone followed by hexametonium, and then you intubate with a cupped endotracheal tube quickly without ventilating the patient. It's very, very important.
Yes, sir.
What is modified RSI or controlled RSI, as some people call it? Earlier it was called RSI alone. When they said you have to only pre-oxygenate and then never bag and ventilate the patient at all until the intubation is completed. But later on they modified it by saying that after giving hexametonium, you wait for the fasciculations to stop, and during that interval of 3 to 5 seconds, you can gently bag the patient without causing any gastric distension. Okay, you can avoid hypoxia by gently ventilating the patient with a very low tidal volume, not the normal tidal volume. That will help you to prolong the apnea, safe apnea period. So that is called the modified or controlled RSI. Okay, so 3 to 4 pieces of the reservoir bag can be done after hexametonium administration also, which is called the modified or controlled RSI. Okay, right.
Okay.
What are the other current methods by which you can, supposing it is a difficult airway, anticipated difficult airway, what are the other methods by which you can avoid rapid desaturation and hypoxemia?
Apneic oxygenation with HF and OS.
So you give high nasal oxygen, very good. Then
Jet ventilation, sir.
jet ventilation, or what is thrive? THRIV.
Transnasal, humidified,
Humidified.
rapid insufflated ventilatory exchange.
Let's say. Okay, so that is the thing that is being used now for preventing hypoxemia. Okay, and if you anticipate difficult airway, what are the other preparations you should do?
So awake intubation, I can plan for awake intubation, fiber optic intubations.
Okay, supposing fiber optic is not available, but the Malamati scoring is Malamati 3, and there's a short neck. There is a very protuberant prominent incisors. There is no fiber optic. We want to give a trial in intubating the patient. So what are all the adjuvants or gadgets you require for treating a difficult airway?
So bougie, video laryngoscope, sir.
Very good. First thing is fillet. We need to bend the tube
Still.
an acute angle, then you may need a video laryngoscope, you may need a bougie. So all the things that are there in the difficult airway cart, that should be the answer. Okay, you should have a difficult airway cart ready for usage of managing a difficult airway. Okay, right. So this is how you give GA. What is the analgesic of choice for GA? When do you administer the analgesia?
Following delivery, I can give fentanyl, sir. 2 mg per kg fentanyl following delivery.
Following.
And IV paracetamol I can prefer, sir.
Very good.
Then suppositories.
So what is induction delivery time and what is the importance of that? Especially when you
Sir,
give.
induction delivery time 3 to 5 minutes, sir.
Why that is important?
Time taken for the IV drugs to cross the placenta and reach the fetus, sir.
Excellent. Very good. So you want to avoid any inhibition of the fetus. The cardiovascular or central nervous system depression to the fetus should not occur. So it is better to deliver the child before the drug that you administer to the mother reaches the fetus. This is why the induction delivery time is very, very important. Okay? So that is what you try to change. Okay? Very good. Okay. That's certainly a good preparation that you have done. So, I think any other questions you want to ask, Amachi? Amachi,
Hello, am I audible, sir?
yeah, it's a,
Yes, sir.
it's a nice presentation by Mani. He answered all the questions well.
Yes, sir.
We move on to the next topic.
Usually the anemia is so common in our middle class and lower strata people, and the nutrition costs you commonly expect in the lower strata. If patients coming from upper class of people, you should think of other causes of anemia as well. Nowadays, most of the patients coming with late pregnancies and infertility, post-infertility treatment. Sometimes when they come with anemia, then your approach towards them be a little bit different.
All the time you have to make sure that adequate oxygen is delivered
Yes,
either by supplementation or correction of anemia before surgery, before delivery. That is the most important thing that you have.
most
That's the basic crux in that. And you must evaluate the degree of anemia and its implications in the patient. Like whether they have gone in for severe congestive failure because of the anemia, long-standing anemia, whether there is pleuritic edema, anasarca, or associated hypoproteinemia. All these things you have to take into consideration. But nowadays, because of the awareness and the government's policy to start iron and folic acid supplementation, even at the primary health center levels, as soon as the pregnancy is confirmed, all these things have helped to reduce the incidence of such severe anemia, which we have seen as students in our student days, later about 40, 50 years ago. That is not seen nowadays. And the worm infestations which were there earlier are also now on the decline because of the hygiene thought and the open defecation systems are not allowed, and all this improvement in the hygiene knowledge of the patients, all this has helped to reduce the incidence of worm infestations, which was one of the primary causes for anemia in the about 30, 40 years ago. Many of the women had hookworm or hookworm infestations, and all that has come down. So, you don't come across that severe cases of anemia with Nasarka or fetal edema, shortness of taste, acutely breathless, and severe and digestive failure. That sort of cases are not very common nowadays. Maybe in the remote rural areas may still get one or two cases, but in the urban areas, generally they have a hemoglobin of say 8 to 9 grams. That is the lowest they may exhibit with. And they respond well if you try to treat them with iron, either oral or parenteral. Very rarely you require a blood transfusion before to correct the anemia in these patients.
So as far as possible, single unit transfusions may be avoided, sir.
Yeah, always for an adult, it is given in Lee. Single unit transfusion is never required in an adult. They can always compensate because up to 500 to 750 ml class 1 hemorrhage, body can compensate. So just for the sake of correcting, giving 1 unit is not at all a good idea. That can be as well avoided completely. So you can go for, you have to plan if severe anemia with a transfusion trigger less than 6 grams, they say you should transfuse. It will require at least 3 to 4 units to, because 1 unit will increase only by 1 gram. So to bring it to
Yes, sir.
8 or 9, you require 3 or 4 units. So the transfusion should always be planned in that way.
Yes, sir. Thank you, sir. It was a nice presentation. Can we move on to the next topic, sir?
Yeah, we will go on.